Welcome back to the deep dive. If you're deep in your graduate studies right now, maybe wrestling with that clinical theories class.
Especially that big one, the case conceptualization paper.
Exactly. This deep dive is really for you. We know it can feel, well, pretty daunting,
Hmm.
especially when you're applying these big psychological ideas to a fictional character.
Right, someone from TV or a book. Our mission today, though, is pretty straightforward.
Hmm.
We want to give you the blueprint
Okay. Yeah.
because the case conceptualization, the CC, it's not just another assignment. It's honestly the most critical piece you'll do early on. It shows you can connect the theory to actual practice.
So let's pin down what it actually is. The sources are clear, calling it a structured clinical narrative,
Hmm.
meaning you have to pull together everything, the symptoms, the person's background, their whole context, and then filter it through one specific psychological theory.
And that becomes the bedrock for any treatment plan.
Right.
And it's more than just a summary. Think of it like your clinical map.
Okay.
It has to be grounded in the data you have and the theory you choose.
A map. I like that.
Yeah, and it's not static. It's not like a fixed diagnosis. It's always evolving, or it
Hmm.
should be. And honestly, it shows your professors how you think as a clinician.
Ah, okay. So it's about the thinking process.
Exactly. It proves you can go beyond just listing facts and actually connect the dots in a, well, theoretically sound way.
Okay, so let's break down that structure. The blueprint we're using has, what, 10 main parts?
10 core areas, yeah. We need to guide you from just gathering the basic info all the way to some pretty deep theoretical thinking and even self-reflection.
Let's start at the beginning then, gathering context.
Right. Section 1, client introduction. Pretty basic stuff here. Demographics, age, occupation, cultural background maybe. But the key is the presenting problem.
Okay, what makes that key?
Well, you need to capture it in the client's own words, or how you imagine the character would describe it. But then you also need your clinical description. The prompt we like was, how would the client describe why they're here in one sentence? How would you?
Oh, interesting. So that immediately sets up two perspectives, the subjective feeling and the objective clinical view you're starting to form.
Exactly. And that flows right into section 2, the clinical assessment. This is where you bring in the observable stuff.
Like the mental status exam, the MSE.
Yep, the MSE. Appearance, behavior, mood, affect, thought process,
Hmm.
the standard observations. And your diagnostic impression, is it provisional? Confirmed. Though with a fictional character, it's usually provisional.
Right.
But here's a really crucial distinction, something that often trips students up. You have to separate symptoms from functioning.
Okay, wait. Let's clarify that. Why is splitting symptoms and functioning so important for this clinical map idea?
Good question. Symptoms are what the person experiences, like panic attacks, feeling hopeless, hearing voices, whatever it is.
Okay.
Functioning is how those symptoms mess up their life.
Yeah.
So a symptom might be severe social anxiety. The functioning issue is they can't leave the house or they lost their job because of it.
Ah, got it. So treatment really targets the functioning.
Exactly. You treat the symptoms to improve functioning. Your goals are usually about functioning.
Perfect. That makes sense. And that focus on impact leads us right into section 3, relevant history. This is where we build out the backstory, right?
But yeah, this is where it gets richer than just data points. It's the narrative.
Yeah.
You organize it.
Yeah.
Think. Developmental history, early life, family, major milestones, any trauma.
Mm.
Then, medical and psychiatric history.
Mm.
Any past diagnoses, hospitalizations. Substance use is huge here too.
Okay.
And finally, social and occupational context. What are their relationships like? Support systems, isolation, education, work history. It's the whole environment. This section is about context, not just a list of events.
Because without that context,
Your theory choice later on might feel kind of random or just tacked on, weak.
right. Okay, so once we have that rich history laid out, the big question becomes, how do we make sense of all this? Which brings us, I think, to the part that often feels the most intimidating for students, choosing the theoretical orientation.
This is absolutely the core of the paper. You have to pick your lens. CBT, psychodynamic, maybe family systems, feminist theory, whatever fits.
And just naming it isn't enough.
Definitely not.
Yeah.
You have to clearly articulate how that specific theory helps you understand this specific person's story, their symptoms, their history. How does the theory connect those dots?
So the key question is,
Which theory makes the most sense of this person's story and why? You have to justify it.
okay, question. Let's say a student picks a really structured theory, like classic CBT. How do they avoid making the CC just feel like they're ticking boxes off a manual? Where's the deeper thinking?
Ah, great point. The critical thinking really shines in the next step, the case formulation. Your chosen theory dictates the language and the concepts you use here.
So the formulation builds directly on the theory.
Directly. You'll usually start by ranking the problem list. What are the most pressing issues? Then you use your theory's tools, maybe it's schemas in CBT or core conflictual relationship themes in psychodynamic, or family roles and systems theory to explain why these problems exist and persist for this person. That's the synthesis part.
Okay, synthesis. And I know a key part of any good formulation, especially at the graduate level, is the 4Ps model. It seems unavoidable.
It really is essential. It gives structure and forces you to think across different time frames. The 4Ps help you organize causality.
Okay, let's break them down.
First, predisposing factors. Think backward. What made them vulnerable in the first place? Childhood experiences, genetics, long-term stressors, the background risks.
Got it. Then.
Precipitating. Think immediate trigger. What happened right before the current problem started or got much worse? A loss, a job change, a trauma.
Okay, the spark.
Exactly. Third, perpetuating. This one's often tricky. What keeps the problem going right now? Avoidance behaviors, lack of social support, negative thought patterns, unhelpful family dynamics.
What maintains it?
Right. And finally, protective factors. Think strengths and resources. What's keeping them afloat despite the problems? Coping skills, supportive friends or family, intelligence, insight, motivation for change.
That framework really maps it out. It answers that prompt. What keeps this problem alive and what keeps this person afloat?
It does. And that whole formulation, that story of why things are the way they are, logically leads straight into the treatment plan.
The action part.
Precisely. And this can't be wishy-washy. Graduate level plans need SMART goals. Specific, measurable, achievable, relevant, time-bound.
Can't just say, feel better.
Nope. Then you need theory-specific interventions. If you chose CBT, you're talking cognitive restructuring, exposure therapy, behavioral activation. If it's Gestalt, maybe empty chair work. The interventions must match the theory you used in the formulation.
And link directly to the goals.
Absolutely. Each goal needs at least one intervention aimed at achieving it. You also need to include a prognosis, your educated guess about the likely outcome with treatment.
That requires some clinical judgment.
It does. And finally, clear termination criteria. How will you and the client know when therapy has achieved its purpose, based on the goals you set?
Okay, plan set. Then we shift gears a bit, right? Towards more reflective pieces.
Yeah, the next sections are vital, but often feel a bit different. Section 7. Cultural and ethical considerations. Super important, especially if your fictional character has a rich or complex cultural background.
You can't just gloss over this.
No way. You need to actively identify the client's cultural identities. Maybe using a model like addressing or respectful can help organize your thoughts. Consider how culture might shape their symptoms, their understanding of distress, or even their view of therapy.
And the ethical side.
You need to flag any potential ethical issues.
Yeah.
For a fictional character, maybe it's about the limits of your knowledge or if you were really seeing them. Things like confidentiality, boundaries, scope of competence. It forces you to think about the professional responsibilities.
And thinking about your own perspective comes next, in reflection. Section 8.
This is where I think good papers become great papers. It takes some vulnerability to look inward.
What goes in here?
Two main things. First, therapist reactions. Any feelings the client stirs up in you. Annoyance, protectiveness, boredom. We call this countertransference when the client taps into your own stuff. Recognizing it is key to not letting it interfere.
Okay.
Second is bias awareness. We all have biases. Age, gender, race, socioeconomic status, lifestyle. You need to reflect on how your own assumptions might be coloring your view of the client or the character.
Okay. And for fictional characters, there's one more piece here, isn't there?
Yes. Critically important. Acknowledging the limitations. What information is missing because it's fiction?
Yeah.
What couldn't you know? What gaps exist in your formulation because the source material didn't provide it?
That shows real critical thinking, knowing what you don't know.
Exactly. It shows you understand the limits of your perspective,
Yeah.
which is crucial in real clinical work where you never have all the data.
Okay, let's wrap up with the last bit, actually writing this thing well.
Right. The final push. Language and structure matter hugely for graduate work. Use professional, clinical language. Not overly academic jargon necessarily, but not casual chat either.
Clear and concise?
Clear, concise, but rich with explanation. Use subheadings to organize it clearly. Makes it much easier to read and grade.
And the idea that this isn't a one-and-done document.
Right. Section 9 is review and revision. Conceptualization is dynamic. So your paper should mention how you track progress. Outcome measurement.
How would you do that?
Could be formal assessments, if appropriate for the character and theory, or informal things, maybe tracking specific behaviors, using a simple rating scale each session, even using journal entries as feedback. You need some kind of feedback loop built in.
And finally, the academic necessity.
References. Got to have them. You need scholarly sources to back up your choice of theory, the interventions you propose, maybe even specific aspects of the character's issues like trauma or addiction.
How many are typical?
For a grad level CC, probably 3 to 5 solid, relevant, scholarly references showing you've grounded your clinical thinking in the literature.
Okay. So putting it all together, this case conceptualization, it's really that bridge, isn't it? Between just knowing facts about someone and truly understanding them through that crucial lens of psychological theory.
It absolutely is. It's probably the highest form of clinical critical thinking you do early in your training.
And doing it with a fictional character. That limitation aspect you mentioned feels key.
It's huge practice. Identifying what's missing prepares you for the real world, where clients rarely hand you their entire life story neatly organized. You always work with incomplete data.
So final thought for everyone listening, especially those starting this paper. Since a CC is supposed to be this living, dynamic map.
Always open to revision.
Yeah. As you start drafting, think about this. What specific piece of information, a symptom, a trigger, maybe an insight your character, suddenly reveals what would be so surprising or unexpected that it would make you totally rethink your chosen theory if they actually walked into your office tomorrow?
That's a great question to ponder. That pushes you to really test the robustness of your formulation. That's the heart of sharp clinical thinking. So get started on drafting that map.